So Dr. Julian Davis is a medical oncologist and hematologist who practices in Santa Barbara. He sees patients with all types of cancer with a specialized interest in hematologic malignancies, melanoma, and clinical trials. He is board certified in hematology, medical oncology, and internal medicine. So let's welcome Dr. Davis.
Thank you for having me. Hi. Can everybody hear me?
Yes.
So thanks for joining. See some familiar names and faces. I'm sure there's some more people that are probably going to be jumping on, might be having technical difficulties, but I wanted to give you just a little background on myself. And tonight we're going to go over kind of an overview quickly of melanoma and some important advances in the last several years, some exciting stuff and kind of where things are headed. I'm a medical oncologist, so I generally manage systemic therapies or treatments that travel throughout the body and treat cancer wherever it is. A lot of melanoma is seen by dermatologists, dermatologic surgeons, and surgical oncologists. And many cases that are small and confined to the skin never get to us in medical oncology, which is a good thing. I grew up in Santa Barbara. I went to UCSB and did biology and did some grad school there. And then was really interested in cancer biology and cancer science before going into medicine. And I went across the pond to Ireland for medical school at the Royal College of Surgeons in Dublin, and then went to internal medicine residency in Philadelphia at Pennsylvania Hospital, and then hematology oncology fellowship in Sacramento, UC Davis. And then was very, very thankful to come back home to Santa Barbara to start practice in 2018. And then more recently, about 2 years ago, Dr. Greenwald and my partner, Dr. Greenwald, and I were able to open up this satellite practice of UCLA January 2021 here in Santa Barbara. So we're fortunate to be part of the UCLA system. I definitely want to keep this thing an intimate and open discussion because we have so few people. So if you guys want to flip your cameras on, that would be great. And if you do have questions, please feel free to interrupt and ask me, and we can kind of do a roundtable discussion as we go through things if questions pop up. So please do that. So no just financial disclosures from me. So what is melanoma? So melanoma is a malignant cancer tumor of melanocytes, which are pigmented cells throughout the body, which are not just in the skin, even though that's the majority of melanoma we see, but there's pigmented cells that can become melanoma on the outer surface of the eye, the conjunctiva. There's pigmented cells inside the eye that can become melanoma, ocular uveal melanoma. There are pigmented cells that can become melanoma in the oral mucosa and vaginal mucosa, mucosal melanoma. And then acral melanoma can happen on the palms and soles, so non-sun exposed areas, and even in the beds of the nails on the hands and feet. So skin melanoma, cutaneous melanoma is by far the most common thing, but there are some more rare subtypes, and they can be kind of related biologically to sun exposure, but many are not. So mucosal melanoma and uveal melanoma inside the eye have kind of different biology, different genetics, different risk factors than skin melanoma. So I'm not a dermatologist, but because of the intimacy that we have with our dermatologists in managing melanoma, majority of cases, as I said, are early stage. So either melanoma in situ, which means that there's some cancerous cells in the very surface of the skin, but they haven't yet broken through the floor or top layer of the skin. So they're isolated. And features that could be potential bellwether for melanoma in the skin are these ABCDE kind of criteria. So things that regular people can look out for A is for asymmetry. So if one side of the melanoma is different or bigger or irregular, different color, irregular borders, as opposed to having kind of a hard border, one that kind of fades in or blends, or not a nice circle. Multicolored, so if there's different reds, pinks, grays, browns, purples, that might be suggestive melanoma versus a single nice solid dark brown. Diameter as in size, 6 or greater millimeters kind of increases the relative likelihood that things could be a melanoma. And then E for evolution. So are things changing or growing over time, or is there a new spot where there's been a background of kind of stable moles? That could be an indication that a melanoma is developing. So that's ABCDE, and you can look these up. And what is recommended these days, what a lot of people do, especially given that we have, great cameras and stuff like that, is people can keep track of their own moles. And you can get a little measuring tape, usually with centimeters, because in medicine we like to use metric, millimeters, and put it against a mole that you kind of are thinking about, snap a picture and put it in a certain album in your phone, and then you can keep track of it over time. And that's where you have a really kind of objective reference and say, hey, I took a picture of this 6 months ago or 8 months ago, and it was smaller, it had a different color, and that can help you decide if it's something you want to bring up to a doc or go see a doc. So risk factors for melanoma, as I'm sure you guys know most commonly, is sun exposure. So UV radiation from the sun causes DNA damage, and that in turn can damage DNA and cause initiation of a process which leads to melanoma. And there's a spectrum, there's kind of a gradient, a way that things can be totally normal to what's called atypical or dysplastic before they become cancerous. So fair skin, lots of sunburns when you're young, tanning beds, those are all specific things that are associated with increased risk factor, increased development of getting melanoma. Fair skin, as I said, something called Fitzgerald skin types, from really, really fair burns easily to very, very dark. A personal history of melanoma or other non-melanoma skin cancer is a risk factor. It kind of shows that you have a predisposition to skin cancer because of your sun exposure or your skin type. So that can be a predictor of future melanoma. In some situations, people who have suppressed immune systems, either because of an organ transplant, like a kidney or lung, because of some underlying blood cancer, lymphoma, which affects their immune system, or viral infection like HIV, can be associated with an increased risk of skin cancers in general, not just melanoma. And then very rarely there are actual inherited genetic familial syndromes where a specific mutation you've inherited from mom and dad can result in a much higher rate of moles and melanomas. So one is called this FAM syndrome, familial atypical multiple mole and melanoma. Or there's some other genetic mutations in genes like BAP1, which we normally associate with things like pancreatic cancer, but they can also lead to increased melanoma rates as well. Any more questions about that stuff? So a quick epidemiology slide. The incidence is a word which means the number of new cases per unit time, so per year, is rising, not just in the US, but worldwide. So here's some data from SEER, which is a big database which looks at medical information, compiles it. The incidence as in number per year of 100,000 people from the 70s to 2010 has gone up, several folds. And it's a question of why this is. Sometimes it's called observation or screening bias. If you're looking for something and you're documenting it better, it appears the number is more, but that may or may not be true. We're probably doing a better job screening because of kind of public health initiatives, knowledge about melanoma, and in some situations, really significant public health initiatives, like in Australia, where you've got a lot of fair-skinned people. There's high UV index in Australia, New Zealand, and they noticed in their health system that more people were developing and dying of advanced skin cancer. So they made it a national public health priority to screen more, to intervene earlier and save people's lives. And so that in turn generates greater incidence, more cases being detected, and probably a lower threshold to biopsy in some circumstances. If you see a dermatologist and you're concerned about something, they might biopsy it just to exclude possibility of melanoma. So unfortunately, about 9,000 people die of melanoma in the US per year. And in general, mortality is getting better, as I'll discuss, particularly with advanced disease because of improving knowledge, technology, and medicines. But it does vary in different age groups. So when we first make a diagnosis of melanoma, we want to consider adequate staging of the melanoma. So usually melanomas are detected and sampled initially by dermatologists who would perform potentially a punch biopsy where they have a circular biopsy needle that can create a little cylinder, which they snip at the bottom and then suture up. Or most commonly a shave biopsy, which can kind of shave under the lesion, or sometimes things are just locally excised, a full thickness. So all of the skin is removed down to the connective tissue or muscle, and then those two ends are sutured back together. So that's the initial biopsy. Primary local therapy for most melanomas is surgery. We call a wide local excision, meaning that the primary melanoma is excised, cut out in its entirety with margins, meaning usually about 1 centimeter outside of the lesion on every side. So that means at minimum, you're going to have a 2 centimeter cut or hole. And then for some melanomas that are deeper or ulcerated, which is a feature that we can see on the pathology biopsy, that have a potential higher risk to have spread to lymph nodes, we perform, or the surgeons perform, a technique called sentinel lymph node biopsy. And this is a shared decision-making event where your doctor, namely the surgeon, and you will talk about the risks and benefits. So thankfully, with a sentinel lymph node biopsy, we can get a lot of information without having to remove all of the lymph nodes in a certain lymph node basin. And this system is also used similarly for breast cancer. This example in the picture over here is a melanoma on somebody's upper arm. That would normally drain to the lymphatics in lymph nodes in the armpit, just like the right breast would drain to the right armpit in most cases. So what the surgeon does, at the same time that they're going to do the wide local excision on the arm melanoma, they'll inject 2 different dyes, a blue ink and also a radiotracer, like technetium 99. And those 2 dyes flow through the normal lymphatic vessels and channels to the first couple lymph nodes where a melanoma cell, a tumor, would travel from the primary to the armpit. And that way, when the surgeon goes in to do surgery, they not only remove the arm melanoma, but they also use a little Geiger probe to find the hot nodes that have the radiotracer, and they dissect down, and they should see that they're also blue because they've taken up the blue ink. And they're able to remove 1, 2, maybe 3 lymph nodes, and send them to the pathologist to look under the microscope to see if there's any microscopic melanoma that's traveled to those first couple nodes. without having to remove all of the lymph nodes in the armpit, because doing that is a more morbid procedure that can lead to restrictions in arm movement and potentially edema of the arm that can be persistent. So it's a very good procedure that provides some diagnostic information. It's not recommended for every melanoma, but it could change our stage from a stage 2, for example, to a stage 3 if we find that some lymph node is involved. And then scans like CT scan or PET scan are really only recommended if positive lymph nodes are found, or if the patient has some symptom or sign that's concerning that melanoma has spread to other parts of the body, like liver, bone, lungs, brain, etc. So primarily, the wide local excision is really the mainstay of therapy for the vast majority of melanomas, which are isolated just to one spot. So here's a slide about staging. There's different editions of the AJCC staging, and they're being updated, but the main staging of melanoma depends on the absolute thickness in vertical millimeters. So when the shave biopsy is done, that little chunk of tissue gets sent to the pathology lab. They embed it in wax and they cut it crossways so they can measure the height or thickness, and they give us a T stage. Is it less than 1, 1 to 2, 2 to 4, greater than 4? And does it have any ulceration where it's lost the kind of superficial top layer of the skin? And that staging is what translates to a certain prognosis. So as you can see in this graph, this might be really small, but this top pink line is a stage 1A melanoma. So a melanoma that's very thin and not ulcerated, which thankfully is the majority of melanomas that we see. And with just surgery alone, the outcomes are very, very good. So the y-axis here is melanoma-specific survival. So that's the chance of not dying of melanoma. 99% of 5 years, 98% of 10 years, very good. And as we go down the lines here, these melanomas are kind of thicker or ulcerated, and you can see that the prognosis overall changes from high 90s to 80s to even the 70s. Stage 2C melanoma would be a melanoma that's thick, like deep, and ulcerated without yet going to the lymph nodes. And over here on the bottom right side, these are the relative prognosis of stage 3 melanomas. And you can see how widely this is varied. In stage 3A melanomas, which even though they're involving the lymph node in a microscopic way, primary melanoma was thin and not ulcerated, so it's kind of a good actor. And the prognosis with surgery is still pretty good overall. 93% not dying of melanoma at 5 years, 88 at 10 years. But if you go down, that worsens significantly. So even some melanomas that have not yet gone to the lymph nodes can have a poor prognosis down in this range. And some node-positive melanomas can actually have a better prognosis than some node-negative melanomas. So it really depends on tonal staging, and the primary depth and ulceration has a lot to do with it. So as we talked about before, the primary therapy for a local melanoma, I mean, just involving the skin or microscopic involvement of the lymph nodes, would be a wide local excision, 1 centimeter margins, done either by the dermatologic surgeon or surgical oncologist. And a sentinel lymph node biopsy may be performed if we feel like there's some chance or a greater chance there could be lymph node involvement. We want to detect that for adequate staging. In the contemporary era, one of the major changes that's happened is we're considering giving systemic therapies, which is what I do as a medical oncologist, potentially either before or after surgery in order to improve the outcomes overall. So the first thing that we did was actually adjuvant therapy, which is just a word that means after surgery. In any cancer, whether it's breast, lung, prostate, colon, or melanoma, we know that even with an adequate surgery, for some cancers, there's some likelihood, potentially a high likelihood of recurrence, either locally or distantly. So the thought is, what can we do above and beyond surgery to improve the outcomes, to improve the chance of cure and decrease the chance of recurrence? So adjuvant therapy means anything after surgery. So whether it's radiation or chemo or immunotherapy or targeted therapy, et cetera. So in certain cases, stage 3 and now in some stage 2 patients, we consider giving some systemic therapy after surgery to try to decrease recurrence. A very novel thing, which has kind of been coming out in the last couple of years, is neoadjuvant therapy, which is treatment before surgery to try to improve outcomes of surgery and improve overall outcomes. So this is really being done not for little melanomas that we think are just isolated to skin. This is more for macroscopic or clinically obvious disease. If people have a melanoma with obvious lymph nodes that are involved, they're palpable, they're bulky, they're enlarged, or they're spread to a region without being distant, we might consider giving some immunotherapy for a couple cycles prior to surgery in order to improve the chance of surgery, to resect it all, and also as kind of a biologic trigger. We think the immune system in the body can kind of do more and know more to respond with immunotherapy if there's some disease there versus then if you've taken it all out. So we're really only doing this when people come in with kind of bulky nodal disease or some other unresectable disease. So systemic therapies for melanoma, which is, again, what I do as a medical oncologist, are medications that travel throughout the body and treat cancer wherever it is. And primarily, they were used for advanced or metastatic melanoma. Melanoma that's beyond the scope of cure with surgery or radiation. They kind of come in two major flavors. One are targeted therapies, and this is an example of called a signal transduction pathway called MAP kinase. If you think of a side cut, here's the surface of the cell, and there are growth factors that are chemical signals that our body releases that help tell which cells to grow and which cells to stop growing. And a lot of these cellular circuitry mechanisms are abnormal or mutated in cancer across the board. And so there's a gene in here called RAF or BRAF, which is mutated in about 50% of patients with metastatic melanoma. And if that is mutated, we think it's kind of driving growth. It's kind of the foot is stuck on the gas pedal and it's not listening to the controls and it's not balanced and able to respond to outside signals. So if we find this BRAF mutation, we have targeted drugs, molecular medications, which are not chemo, they're small molecule drugs, they're pills, they're given orally, and they can work by inhibiting these proteins in this pathway to block this kind of gas to the floor effect. And they can work really, really well. In metastatic melanoma, these medications are not considered curative, but they absolutely can cause responses, shrinkage of the cancer, prolong life, and improve symptoms. But again, this mutation is only present in about 50% of melanomas. So if you don't have the mutation, the oral meds don't do anything. And this BRAF mutation is something that's been acquired by the melanoma. It's only in the melanoma. It's not something that's inherited from mom and dad. It's not present in your other cells of your body. On the flip side, on the right side here, is an example of our contemporary immunotherapy namely the PD-1, PD-L1 drugs. There have been many generations of immunotherapies throughout the decades. We've known that melanoma kind of provokes the immune system, and sometimes when we actually do a biopsy, we can see regression, meaning that the immune system has already started to kind of infiltrate the melanoma and try to fight it and kill it even before we've given anything. But this specific interaction won the Nobel Prize in Medicine a couple of years ago on decades of work, and this class of drugs have become the biggest drugs in oncology in the last decade, not just for melanoma, but now used for many, many different types of cancer. Doesn't work in every cancer, but kind of revolutionized many cancers, and melanoma was the poster child for this class of drugs called checkpoint inhibitors. So the idea is that the immune system is always trying to surveil the body and take out little cells that are becoming cancer. But the cancer cells are good at hiding themselves, disguising themselves from the immune system, and also shutting down the active immune cells like the T cells. So this PD-L1 is actually an inhibitory signal that shuts down your lymphocyte or T cell. And what the drug does, here in this case called pembrolizumab, there's another one called nivolumab, Keytruda and Opdivo, they block this inhibitory signal, which is kind of a double negative, thereby activating the T cell so it can recognize and kill the melanoma cell. So the way I like to describe it is you're not just activating the immune system in general, you're kind of ripping the camouflage off the cancer cells so the immune system can see it and do its job. Here's a question. Thyroid cancer with a BRAF mutation. Do you know if there's any connection with this? Not directly. This signal transduction pathway, MAP kinase, is frequently mutated in many, many, many cancers. Thyroid cancer, lung cancer, colon cancer, across the board. And so in each individual cancer, there are certain components of this pathway that may be mutated or not. But if we find BRAF mutations, we use the same drugs. So thyroid cancer with BRAF mutations can be sensitive to the same BRAF targeted drugs that we use for melanoma, which we also use for colon cancer with the same BRAF mutations. So kind of applying a drug that was approved for one cancer to another cancer with the same molecular signature. I hope that. Will be part of the all right, let's keep going. So the good thing about the immunotherapy is that it doesn't matter what your BRAF status is, whether it's mutated or not mutated, you can still respond to it. And in some patients, as I'll show you with some data, you can have incredibly good and potentially durable responses, even in advanced or metastatic stage 4 disease. So here is kind of a calendar, a map of a lot of different medications which have been approved by the FDA over the last decade plus. And this has really been the huge paradigm shift and change in landscape of melanoma, period. Back here in the 90s and early 2000s, there was dacarbazine, which was a chemotherapy, like real traditional chemotherapy, which yielded in advanced melanoma or stage 4 melanoma, where only about 15% of patients were alive at 2 years. The first generation of immunotherapies, so interleukin-2 and interferon, which are naturally occurring chemical signals that we release when we get sick with the flu or something like that, were used to be given in high dose. People got really sick. They felt sick. Many had to be in the ICU, but a small percentage of them had good and potentially durable responses. So it was kind of like an inkling. There was a twinkle that there could be this amazing immunotherapy response, and we just had to learn how to do it more effectively and more safely. The kind of modern era begins around 2010, 2011 with the approval of ipilimumab, which is the first immune checkpoint inhibitor, first approved for metastatic stage 4 melanoma, and then later, 5 years later, approved in the adjuvant setting, meaning after surgery to decrease the risk of recurrence. And this worked better and was less toxic, but still significantly toxic. And when I say toxic, I'm talking about immune-related side effects. So the upper half of this page with the red drugs, those are all immunotherapies. And then simultaneously below the timeline are all the targeted therapies for patients with BRAF mutations. So there was a single agent BRAF inhibitor called vemurafenib and then dabrafenib. But then we realized that when we combine it with other drugs that inhibit other components of that signal cascade, we're able to get deeper and more prolonged responses. Ipilimumab was the second generation technically, but the first immune checkpoint inhibitor. And then along came the PD-1 twins, pembrolizumab and nivolumab, Keytruda and Opdivo, and those were first approved for metastatic melanoma. And they significantly improved outcomes. Nivolumab was compared head-to-head against ipilimumab and was both significantly better, as in more effective, and also much less toxic. There were still immune-related side effects where the immune system activates and can attack other healthy tissues of the body, but the rates of those effects were much lower. TVEC is a genetically engineered herpes virus that's specifically engineered to kill melanoma cells. That's actually injected into the melanoma lesion. So we do that usually for kind of accessible cutaneous spots or for lymph nodes. It's a little technically challenging, but it can have really good effects. And then, as you can see, many of these drugs, which were first approved for stage 4 metastatic melanoma that spread to multiple parts of the body, were studied then in the adjuvant setting. So after surgery for stage 3 melanoma, for example, giving a year's worth of immunotherapy could decrease the chance of recurrence versus giving placebo. So both nivolumab and pembro were approved for stage 3 melanoma, and then more recently, pembrolizumab, Keytruda, was studied in high-risk stage 2 melanoma. So melanomas that haven't even gone to lymph nodes. If they're still deep and ulcerated, meaning high risk for recurrence, we offer a year's worth of immunotherapy, IV infusions given every 3 or 6 weeks in order to decrease the chance of recurrence. Very recently, in the last year or year and a half, another medication called Opdualag, which is a combination of nivolumab, which is a PD-1 blocker, and relatlimab, which is an immunotherapy drug, but against an entirely new target, a totally different surface molecule, that's been approved, and that was compared against nivolumab alone and improved outcomes. So this single slide encompasses an incredible decade of progress, from 15% of patients alive at 2 years of metastatic melanoma to now the 2-year survival is on the order of 60-something%. This slide is the only data slide that I'll show, but these are what are called Kaplan-Meier survival curves. So on the y-axis is, on here on the left, this is overall survival. So this is the percent of patients who enrolled in the clinical trial that are still alive at these time points. You can see in months here on the x-axis. So the red-orange line are patients who got combination 2 immunotherapy drugs together, nivolumab and ipilimumab, in stage 4 metastatic melanoma. And as you can see, this survival curve kind of starts to plateau out where, at 60, 72, 90 months, about half of patients are alive. And if you compare that to what the outcomes were, even 5-10 years ago, it was a lot worse than that. So this right side is progression-free survival. So this is patients who are both alive and without progression. And that's kind of pretty stable in the 30s%, after 3 or 4 years. So the point is that if you get these medications, some patients can actually have really durable outcomes in a cancer that was previously considered incurable. Some patients are cured because they're continue to be alive for 5, 6, 7 years out. And many patients actually by now that were on these studies have stopped the therapy because we think that it may not be dependent on the drug anymore. We might have kind of educated the immune system on how to take care of the cancer, and it's not dependent on the drug. Some patients had to stop the medications much earlier due to side effects and also had a great response to treatment. And we've just watched them and they've maintained a great response off the drugs. So that's pretty amazing. Let's go to our next slide here. So here's an example of a patient of mine. She showed up with a bunch of bulky lymph nodes. They were clinically palpable. She had a history of a melanoma on her arm that was locally excised. We did a biopsy of these lymph nodes and found it to be metastatic melanoma. She also actually had a lesion in her lung too, so she was stage 4. We enrolled her on a clinical trial with a novel immunotherapy combination. And after a couple cycles, you can see that huge, bulky lymph nodes was down to 1 by 1.5 centimeters, and the thing in the lung had dried up. And she tolerated it really well. So this drug that was studied that we had here in Santa Barbara open as a trial is now approved, and that's the Opdualag combination. So it was really cool to kind of participate in a phase 3 trial, which kind of led to the approval of a new medication, which is another option for people and generally well tolerated. On this side, this is another patient that I had. These are PET scans. So at diagnosis, he had a large volume of metastatic disease. So all the black areas, so the brain is normal uptake of the sugar tracer, and the bladder always lights up. But all this other stuff was both metastatic melanoma in the bones, like arms, spine, ribs, pelvis, and a ton of bad spots, metastatic disease in the liver right here. And because of his high burden of disease and because he had a BRAF mutation, we started him on the oral targeted therapy and was able to, rapidly decrease his tumor burden and improve his general health. He, was really, really sick before and kind of able to get back on the horse and have much improved quality of life, activity. He was exercising, going on walks, eating well, appetite improved. And you can see the response in the liver where we really can't see any active disease anymore. Unfortunately, it doesn't mean that he was cured, but we set out to their goal to prolong his life and maintain or even improve his quality of life with therapy, and thankfully have the capability. So obviously, an ounce of prevention is worth a pound of cure. And I was just listening to NPR this morning how, sadly in America, as far as budget for preventative medicine, it's, single digits percentage of overall healthcare expenditure, which is, a bummer. Sun protection is obviously key. People know that. Wide brim hats, long sleeves, sunscreen, at least SPF 30, no tanning beds. And then early detection and treatment is key. If something's a melanoma in situ or a little stage 1 thin melanoma that can just be excised, that's curative in the vast majority of cases. And if that's treated and cured, they'll never see me in medical oncology, which is what our goal is. So being active in your own surveillance, taking photos, having a little tape measure, and that's going to yield better outcomes. In general, preventative measures for cancer include weight loss, healthy balanced diet, don't smoke, and get your regular screening like colonoscopy and mammograms. if everybody did that, we'd have a significant decrease in cancer cases and cancer deaths overall. So that's all the slides I have, but I'm happy